Jody Crane is going to introduce himself. He's just kind of setting up the AV, but we thought we'd just kind of get started, do some introductions. Amy, you want to introduce yourself?
Yes, sure. Hi, everyone. I'm Amy Forsberg. I'm a nurse by trade. Been in healthcare over 20 years. I've been nursing director of an ED, similar to yours. Lots of psych, peds, had 110,000 visits. Done some other leadership within nursing. I've been with Team Help for about 3 years, and I'm a consultant with them and liaison to the nursing piece. So happy to be here. Thanks for having us.
Is Tracy here? Tracy's here.
Oh, okay, Tracy's in the bed huddle.
Okay.
She's in empty go around.
Yeah.
Already.
Okay. So just show of hands. How many are nurses here? Techs? Great. Registration? Awesome. So we got a little bit of everybody and physicians. So we got a couple of physicians. Okay. So, as we kind of undertake this Press Ganey project, we are including everyone because everyone makes a difference in the ED. It's not one individual, but the whole department that gets this facility better. And, I was shadowing, some physicians and just the ops and just the team yesterday, and I saw some amazing things. I saw this one nurse just, as they couldn't enter a patient's room, immediately went and got a blanket and a pillow for this patient. But what I did see is how they messaged that kind act. So the patient didn't even realize they were given this blanket and pillow. And so the start of this kind of project is kind of the awareness and the messaging of what we do for our patients. And so this nurse could have easily said, "Miss Smith, I see that you're cold. Here's a blanket to make you a little more comfortable. Miss Smith, here's a pillow. And this is, I know that your back's probably going to be sore on this gurney. This is to help you make you feel a little more comfortable." And so those are kind of the messaging things that, we can kind of just get this facility to kind of transform into being a patient-centric and to kind of get acknowledgement when we talk to our patients. So the kind acts are there. The quality of medicine is there at this facility. It's just the soft touches and how we message things to the patients that's going to make a big difference and drive your scores. Jody, you about done?
We are ready. So how you guys doing today?
Good.
Good, awesome. All right. So like Lauren said, my name is Jody Crane. I'm the Chief Clinical Officer for Team Health Emergency Medicine. So we have facilities in 49 states. We have about 500 emergency medicine contracts. I oversee all of the emergency medicine service line as well as performance improvement in our organization, and have done a ton of work around patient excellence and service excellence, and felt like it'd be a great opportunity. Chris asked us to come up and just teach you guys maybe a new slant or a new way to look at the patient experience. So how many of you guys feel like you do a really good job right now satisfying patients in your department? Okay, so you feel like you're pretty good. So when you're leaving your shift, you feel like every patient walked out of there pretty happy. Yeah? Anybody think you don't do a good job, or anybody think you could do better? What are some of the things that you do that you feel like patients really like? What do you think patients really like when you're kind of working on communication? Okay, what else?
Compassion.
Compassion. Okay, show compassion. How do you show a patient compassion?
Come in, see they're in pain, address it. If they have a question, you don't have the answer, get them the answer.
Okay.
Show a sense of urgency.
Okay. Anybody else? Do you think patients just kind of inherently know you're displaying compassion, or do you think they know, like Lauren said, do you think they know that that when you give them a pillow, it's because you're concerned with their comfort, or what do you think?
I say it's the little things like that. We give them the call bell, you know, make them aware of their surroundings, fix the bed for them, pillow, blanket, and stuff like that.
Yeah, what were you gonna say? Oh, was that you? Okay.
Yeah, I was just gonna add a confirmation. I think a lot of times when patients present, at least to the emergency department, very unsure if they should even came and if they made the right step. And I think that's a big step.
That's a good point. One of the worst things you can do to a patient is say, this is an emergency, you don't need to be here, right? It's confirming that they are indeed in the right place. And I tell people that all the time when they come in. I'm like, man, I'm so glad you're here because I'm a doctor, and if I were at home, I wouldn't be able to figure this out without at least a couple of tests, right? And that makes them feel good about why they were there. So good, and I appreciate all of those things, but it turns out if we really want to be top performers, and Lawrence will kind of show you guys your data in a little bit, but if we really want to be top performers, we have to kind of go above and beyond the normal things that we do. We have to create a series of wow experiences for the patient. And that sometimes can be difficult when you're struggling through your shift. You know, it's a busy shift, you got a bunch of boarders, you got a bunch of people in the waiting room, you may have a drug seeker or somebody that's driving you crazy. It's hard to kind of step outside of that or keep yourself outside of that and do the small things that patients really appreciate. So, I don't know what happened. We ended up getting the clicker, but I'm going to hang out up here until we get it. Okay, so we're going to talk about why focus on patient experience. We're going to talk about who the customer is, some key areas of focus. We're going to talk about the nursing piece, and then Lawrence is going to talk to you about what they do at his big EMC practice. So one of the big things we talk about when we frame the patient experience and patient satisfaction is what's a satisfied patient? What makes satisfaction? And satisfaction is perception minus what they expected. So pretty easy equation. If what they perceive was greater than what they expected, then they're going to be satisfied. Okay? And you guys have complete control over what the patient perceives, both negative and positive. When you walk into a room and you're grumpy, the patient's going to perceive that you're grumpy. You know, and they're going to perceive that you're in a bad mood, and that's going to put them in a bad mood. If you're positive, so I think it clicked in, so okay. So if you're positive, you express concern for the patient, and you keep them informed, and you're working with them, you can shape just about everything. You can shape what the patient expects as well. So, you know, next time you order an x-ray on a patient, just say, hey, you know, I think that x-ray is probably going to take about 90 minutes till I'm back in the room talking to you about your results. Okay? And you know it's only going to take 60. Right? So you've set an expectation for the patient that you're going to exceed. And that's one of the key drivers, that's one of the key tactics we can do, is just tell the patient what to expect, but know you're going to beat what you tell them. So the focus on patient satisfaction is enough to make you sick. How many of you guys feel like? You feel like you've been just like, why are we bending over to help these patients feel satisfied? I mean, our job is to save lives. Our job is to deliver high quality care, all of that stuff. Do you guys feel like you want to satisfy patients, or you feel like you're getting kind of being beaten over your head? Does everybody in the room want to satisfy patients? What are the benefits of satisfying patients? So why should you want to satisfy patients?
Turn business,
What's that?
turn business recommendations towards our hospital.
Yeah, so it makes your hospital look good for sure, right? What else? They're people. I like that one. They're people. Like, I mean, what if they walked into your house? How would you treat them? Right? There's the humanity piece of it, right? What else? Heard something in the back.
That's what we get paid on.
That's right. That's right. So do you want your hospital to get paid? Absolutely. So it turns out hospitals that have higher patient satisfaction scores get paid more. Hospitals that get paid more means you guys either have more staff or you get paid more. What else? So it turns out when you satisfy patients, you're more satisfied as caregivers. And that's well studied in the literature. Satisfied patients equal satisfied caregivers. Satisfied patients equal high hospital profitability. Anybody want to get sued less? Or anybody not want to get sued? So it turns out if you're in the bottom quartile versus the top quartile, you're twice as likely to get sued. You know, angry patients or dissatisfied patients tend to do things differently. And engaging in this whole element of performance improvement and working on processes creates this environment where you're happy to come to work, and that makes the patients happy as well. So there's a lot of good reasons to focus on satisfaction. It's an uphill battle though, and I'll tell you this. So this is Press Ganey patient satisfaction trends over time, and what you see, it doesn't show up. What you see is it goes up over time. So what if you guys reached a really good level of patient satisfaction performance in your hospital and you just said, okay, we're done. Turns out everybody else is going to keep going up, and therefore you're going to be going down. So we all get paid. So hospitals get paid on the patient experience now. So everybody's going to be continuously pushing it, trying to push it higher. So just like Einstein said, everything's relative. So you can't kind of sit back. You have to be constantly focused on this patient experience. So who are the customers that we're focusing on in the ED? Who are our customers?
Patients.
So patients are customers for sure.
And their family.
They're families' customers, right? And this is one of the really important things that Lawrence is going to talk to you about. Acknowledge every person in the room because they're all your customers. Matter of fact, with kids, the parent is actually the one that's going to fill out your patient satisfaction form. Even like teenagers, like it turns out the mom or the dad is the one that you're really trying to impact positively. I mean, you're obviously trying to get it right for the patient, but realize there's more than one customer. There's also different types of patients and different types of customers within our patient subcategories based on their needs. And I'll focus on like a low acuity patients, like somebody coming through the ECU. These guys value speed, convenience. They just want to get in and want to get out. And a lot of ER folks have a problem with that. I don't really have a problem with that. I just want to get them in and out because that makes me happy, that makes them happy. But they assume they're going to get good quality care. They assume you're going to do it right. But they're looking for those things that you would find in any like Starbucks type of experience. We'll talk about that later. And this is an example of that. This is a lady who wrote a letter about my hospital back in 2007. Mary Washington Hospital showed kindness, competence in crisis. So this is a letter about how kind we were and how competent we were. But her son basically bonked his head on the coffee table and had a bleeding like half-centimeter lac. My son and I were drenched in blood. You know, she's freaking out, right? Is this an emergency? What do you think?
To her it is.
Absolutely. The prudent layperson standard would say, absolutely, this is an emergency. When the patient walks in and bleeding's maybe dried up a little bit and she presents to triage, what are we thinking? This is a fast-track patient. This is a lac, right? This is a quick in and outer, right? So right off the bat, we've got a different perception about the way we view this patient and the way the mom views the patient. But listen to everything she wrote. They took us right into triage. We were quickly given a room. We were in and out of the hospital in an hour and a half. What's this letter about? It's about speed and efficiency. And that translated into kindness and competence. Your processes drive the way people perceive you as providers. Your skill, and it actually translates into whether you were nice or not. And it says, I was not just happy about the service we had just received. The truth is, even if it had taken 10 hours, I was eternally grateful that the hospital was just there. Would we have gotten this letter if they spent 10 hours for a half-centimeter scalp flap? No way, right? It would have been a very different letter if it had made the paper. So we have those vertical patients, and we need to approach them very differently. And it's all about speed, efficiency, and reliability. These horizontal patients are different. They're there because they're worried about their life or their limb or their dignity in some cases. They're having a stroke or a heart attack. And they value a lot of different things. They want good care taken care of them. They want to make sure that their safety is top of mind for them. So we approach these differently. And a lot of these patients get admitted, right? Do we get credit for those patients? So if I'm looking at the satisfaction in the department, turns out you don't even get credit for the admitted patients.
Before they go to
Well, so the hospital HCAPs, they actually inherit whatever you did to them. So if they had a horrible experience in the ED, then their HCAPs are gonna be lower. So this is, how would you rate the hospital, and this was likelihood to recommend. This is admitted in the ED versus admitted from the OR or an outpatient. Same thing on both sides. So what we know is if they have a bad experience in the ED, or if they're boarding, or we have some issue, any patient admitted in the ED, generally speaking, has a lower inpatient satisfaction score at the end of their stay than if they're admitted from an outpatient. And that's kind of humbling for us, man, because we got to do some work on those patients. But this is important because that HCAPS, inpatient HCAPS, drives 22% of the inpatient at-risk dollars for reimbursement. So, and I know that this is the case here. Your scores on patients admitted from the ED are lower than scores on patients coming from the outpatient treatment. So this is not your data, but your data looks like this. And it's really important for us to acknowledge that. So we do need to take good care of every patient coming through the door. And we're going to show you some tactics there. We talked about parents being the customers for kids. Everybody plays a role in this. So doctors, nurses, I'm glad everybody's here. Doctors, nurses, techs, registration. Every step in the process is an opportunity for you guys to fail or succeed. And it's all about how you approach the patient. I love that comment about their people. And you know, one thing as caregivers, as providers in the ED, we tend to think about people as chief complaints, right? Oh, hey, there's a chest pain in room 3, right? But we tend to kind of lose the fact that they're just people. And it turns out if we focus on the people first, we'll be good. So I'm going to talk about operations, behavior, and service. And then I'm going to hand it off to Amy. She'll talk about the nursing piece, and then Dr. Hahn will give you some specifics. But operations is probably the most important element of satisfying patients. It's actually the highest leverage thing you can do. And what this shows, this is 1.5 million patients, and what that shows is patient experience decreases based on how long they're in the department. So it turns out that breaking point is the 2-hour mark. So every patient you can get in and out of your ED in under 2 hours, you pretty much don't have to do anything else to them. They're going to be pretty satisfied. But look, it's 76.9 if they're there for 6 or more hours and are discharged. So this is first percentile, that's 99th percentile. Just the difference in a couple of hours. And actually, and this doesn't mean you need to discharge every patient in under 2 hours, but it means every additional patient that you discharge in under 2 hours is going to move from a 4 to a 5. That's all we're looking at. We're trying to move 4s to 5s. So reliability, and this is how do we create the same experience for every patient that walks through the department. So picture a patient walking in at 6 a.m., the department's empty, they come in, you see them in a timely manner, they get a quick x-ray, you tell them the results, and they go home. Picture that patient versus the one that comes in at maybe 6 at night. The place is exploding, you've got people in the waiting room, you've got people in hallways. Is that the same experience that patient that comes in at 6 at night is going to get? No, it isn't, right? It turns out you have to have a reliable process in order for you to do things like to say to the patient, hey, I'm ordering an x-ray, it's probably going to take an hour. You gotta have a reliable hour turnaround time on your x-ray. You've got to have reliable processes to get them there and get them back. So this reliability piece is key. So, your ECU process is a good example of that. Would you guys say that's reliable? Does it occur the same way day in and day out? Yeah, so we got to hardwire some of these processes, especially for the easy patients that are just going to end up going home. And even some of the vertical 3s. Dealing with waits and delays. So we want to reduce the waiting that your patients see. Or if we can't reduce or avoid it, we've got to make sure we communicate effectively about those waits and delays. And I've got a list of things. We won't have to go too much into it. The most important things you guys can do for patients is get them in process the minute they walk through the door. Okay, the minute a patient walks in to be cared for, imagine this, they're seen by a doc and a nurse together, and we're drawing their blood, we're collecting their fluids, and we're sending them to wherever they need to go. That's the most critical action you guys can take in your ED, and you need to make sure that happens every hour of every day of the week, is the way I look at it. And there's other things that you can do too that Dr. Hum will talk to you about. So, and I want to impress upon you guys the importance of processes. So, I worked in a pretty crummy ED, a kind of ED, 108,000 visits when we were at our peak. But, you know, we were in about a 72,000 visit ED. And on our night shift, I would walk in, there'd easily be 50 patients in the waiting room waiting for me. So every patient I was going to see that night was already there. So I wouldn't even have the hope of seeing the people that arrived in the overnight. So it was a really, really poorly run ED. Our length of stay for discharge patients up here on this axis was about 4 hours for discharge patients. It's pretty long. And over this, from 2004 to 2010, we got it down to 2 hours and 45 minutes pretty consistently. So we dropped our length of stay by an hour and 15 minutes. And the blue, so the blue is our length of stay, and that's in the face of 50% volume increase over that same time period. So our volume was going up 10% per year over a 5-year period. And that length of stay drop drove this patient experience. So we went from 66 raw score, which is the lowest in our cohort by a long ways, up to 80 by the end. And you notice this, we had like nine out of, I don't know, let's see, 1, 2, 3, 4, 5, 6, 7, 8. 8 out of 11 or 12 months above this 80 score. And it kind of correlates with all of these little dots down here. So that's that connection between length of stay and the patient experience. So patient experience is going to go up. And we actually replicated that in 3 EDs, so a small, medium, large, just implementing the same processes. So operations is important. If you can't get the operations down, what do? You gotta, well, actually, I would say operations is a big piece of it. Behavior is another piece of it. And we're gonna talk to you a little bit about behaviors. And there's a famous ER doc who gives lectures all over the place named Greg Henry. And he said, emergency medicine is show business for ugly people. What does he mean by that?
You have to smile and be kind and courteous regardless of how the patient is interacting with you. You have to be on all the time.
Yeah, because you are on show. You are the show. You know, you're that Noah Wiley, you're the ER show. You know, when patients come to the ER, yeah, they're getting care, but they're also looking around and they're watching everything you're doing, right? And when you're working on your Epic chart, what do they think you're doing?
Shopping.
Yeah, they're playing Words with Friends or something, right? They just think you guys are doing something else besides providing. So everything you do is on display for the patients, and they're going to critique you. And it's kind of a tough place to be because, you know, the people that built my Toyota Tundra, I don't know what they were doing when they made my car. I don't even know what the factory looked like, right? But they know what your workplace looks like. They know what you're wearing. They know everything that you're doing over the course of their stay. So we're on display whether we like it or not. So this communication piece becomes very important. We need to tailor our communication to the patients that we're treating. You know, hopefully you guys aren't texting your patients, but Dad, I got my girlfriend pregnant. What? Nah, just kidding. I just failed my bio exam. Oh, thank God. Smart. So this communication and our actions are really key. And Lawrence is going to take you down a road here that's going to give you his 20-step process for the things that they do in interacting with patients. And this is doctors, this is nurses, this is everybody in the room. There's these targeted actions that you can do that really make a difference for patients. So we're going to highlight some of these. That's just a list. Dr. Hum's got another list. This is a study that was done on physicians, but all of these behaviors, any of you guys can use them. And what this guy did is he took a group of his docs and he separated them into low performers and high performers, and he studied all of their interactions with patients, and he said, here are the key drivers of the top group of physicians. What do you guys think like the number one driver or 1, 2, and 3 drivers of high-performing patient experience providers were in this study? What do you think is number one? Anybody?
Door to downtown.
No, because that's not like an observable behavior. They didn't kind of study that. Yeah.
They sat down, that's how.
No, and that's not even in this study, believe it or not, but that was not one. Anybody else? Come on, throw it out. You guys know all these things.
Smile.
Smile, no.
How we interact.
Sitting down, no.
How we talk to each other.
No. Communication with other people, no. What else?
Introduce themselves.
Introduce themselves, no.
Appearance.
Appearance, no.
I don't know, hug them and stay.
Hug them. No. What?
Time of stay?
No. These are specific behaviors that these guys. Okay, I won't torture you anymore. But number one, and it made a 17-fold difference. So you were 17 times more likely to be in the top box versus the low box if you did this one thing. Apologize for the wait. So you walk into the room and say, "Hey, Miss Jones, how you doing? My name's Dr. Crane." Introduce yourself to the family member and say, "I'm very sorry you had to wait." Even if it's like just 10 minutes. "I'm really sorry you had to wait. It's crazy busy here today." So that's number one. That's a 17-fold bump getting you to the top box. Number two, overestimate the time. "Hey, you're getting an x-ray. We just talked about this. You're getting an x-ray. It's going to take about 90 minutes. I'll be back in to see you. You're back in 60 minutes. You've won." At least one non-medical gesture. What's a non-medical gesture?
Handshake.
No, I mean, I heard therapeutic touch. That probably falls in a different category too. What's a non-medical gesture? Huh? No? Get a blanket. Get them some ice water. Just lower or raise the head of the bed to express, comfort. Something that you're kind of doing for them as a person that you would do for any person not in a clinical setting. Think about it that way. Something that you're doing to kind of provide them better care as a human being. So that's a fourfold bump. And there's some other ones here. How can I help you? Shake their hands. So some of you guys said shake their hands. That's a benefit, just not like the most benefit. Smile, make eye contact. So those are some of the things that we can do as behaviors, and Dr. Hum's got a list of about 20 of them, and that's what we're doing when we're shadowing some of you people around in the emergency department. We're kind of looking for those specific actions. And then there's other things that we do. And it turns out if you don't have your operations, like let's say your length of stay is really long, it turns out you can still be a high performer. So if you look at that top row, that's basically 98%. And what that top row says is if I'm communicating about delays very well, so I'm getting a 5 on that ranking, then I'm gonna have a likelihood to recommend that's top box as well. So even if things aren't going well, just communicating to patients about their delays will take you there. So communication is really important. And there's these famous companies, so if Disney ran your hospital, it tells you how to get top box scores. And it's all about shaping that experience that we talked about. The Ritz, they're famous for training their employees to using scripting. Does anybody script the way you talk to patients the same way every time? What Ritz does is when you're a new hire, they give you a list of things you have to say to patients, to people that come into a Ritz hotel. And they say, yeah, for the first month, we want you to do these exactly. After that, you can make up your own script, but we want you to communicate in a certain way during these key parts of the customer experience. The best people at patient experience use the same scripts patient after patient after patient. And you can use a script and it can be real. Okay? Just because you're saying the same thing over and over again doesn't mean it's not sincere. And then the Starbucks experience is just about making that wow experience every time. And I'm going to skip over this. You guys do callbacks, you guys do hourly rounding. These things can positively impact the patient experience, but I think they're a good complement to these things. But I think you win the battle in front of the patient with nurses, techs, registration folks, doctors, APCs. I think you win on the ground, face to face with the patient. We're going to show you a little bit more about how to do that. So, Amy, you ready?
Yes.
Okay.
Got the clicker, the
Yep.
hand up at the top. Okay. Okay, hello. All right, we're going to talk a little bit about some strategies with specific to nursing, when we include nursing. Really kind of they apply to everyone. And I understand you've had some patient experience training in the past. Have a lot of you participated in that before? So I'm here to say that probably what I'm going to tell you isn't going to be brand new silver bullet. Doesn't mean you don't have to listen or all get on your phones, but it's a good reminder and then practical tips. And there is a lot you could do for patient experience. There's a lot of information out there. So in order to make this, take this elephant in the room and make it doable so that we can eat it one bite at a time, there's this great study that Press Ganey did to help kind of guide us. Is this a... No, it's not. Okay, so this is a study that Press Ganey did. And they looked at 900,000 patients, how they rated their experience in the emergency department, and correlated the responses on their answers to a positive result. And what they came up with, they kind of broke it down, and this is going to help us focus where we can get the most bang for our buck, how we can eat that elephant. And they started with, at the very top in the middle, did staff care about you as a person? And what they found is when they correlated this, that 92% of the people that answered yes to this question, 92% then would definitely recommend the hospital if that was a positive response, if they felt like staff cared about them as a person. So that's the first one. The second one is if they then answered, looked at, was your doctor, and we're going to go ahead and insert nurse here also, dedicated to keeping you informed about your treatment. If this was a positive response, the correlation was 96% then went on to recommend the hospital. And then takes us down to the third one is, were you kept well informed about your delays? And this correlation was actually 98%. So being kept well informed about delays, 98% of those patients then went on to recommend the hospital. So using this, correlation kind of is going to help guide us, just like an open book test. Where do we start? Where can we focus? What's the most bang for our buck? Or did I press the wrong button? If I just press them all, which one is it? Volume? No, oh my gosh, total user error here.
We've got like a side menu,
If I just press, oh I got it. Oh my gosh, I didn't even see it.
but I don't know how you do that. There you go.
Oh my gosh. No, oh, intro.
Yeah.
What if I did that? Oh my gosh. Help. I need to phone a friend. Why can't I can't work the remote? I need a lifeline. How about if I just go up here? Old school and use this.
There you go.
I don't know if you, oh, did you do it or did I do it?
I don't know.
Jody left, okay, I can do it from up here, let's do it. Okay, sorry about that. The Ritz-Carlton, Jody, Dr. Crane spoke about this a little bit and their great customer service that they have there. Just the other thing I'd add is, once they've gotten their training and they don't have to use the scripting anymore, they're allowed to use the others. They also give the employees like $2,000 a day that they can use to reverse a situation, should it come to that. And actually the studies have found that they don't need to use that because they're so in tune. They're ladies and gentlemen, caring for ladies and gentlemen. They believe in their motto, and they're able to provide the service that needs without having the service recovery. But it's nice to know it's there if they need it. Okay, so we're going to kind of move to the next. Are you still pressing it, or am I don't know if I. Maybe we both see. I'm a button presser. I just keep pressing until something happens. So if all of a sudden it just flips through all the slides and goes to the end, we'll know that we got somewhere. Okay, so first of all, the first one we talked about was keeping you informed about your treatment. And what does anybody remember the first slide that we spoke about before I had the clicker problems? What was the correlation between keeping you informed about your treatment and would recommend? Does anybody remember the number? Oh.
Where do you go forward? Where are you trying to go?
Oh, where are you trying to go? Okay, what about, yeah, that was 96%. Who said 96? Win the prize, okay. But how do I do it? It's working. This button right there. Okay. What if I want to go right that way? Okay.
Yep.
All right. Okay, I got it. All right. Always know your clicker. Okay, what about staff cared about you? Do you remember what the correlation was for that one? 92%. Yep, 92%. And actually, there's a Gallup poll that said nursing is one of the most caring professions and trusted professions. And so, in order to accomplish this with our community, with our patients, it's showing the patients that we cared about them. And there's several tactics that are just the basics to showing that you cared. And they're up here. One of them is asking questions to confirm that you're meeting their needs, which includes, I know this can be stressful, validating that they're in pain or they look uncomfortable. The second is body language. So eye contact, slowing down, sitting at the bedside, holding their hand. These are some of the, I heard some of these things earlier. And then the last is just acknowledging that they're in pain or suffering, and that they're uncomfortable. So those were the basics. There's additional strategies to help elevate this and really helping them know that you care about them. And that is things like welcoming, acknowledging them. It's remembering you're on stage. So this always makes me think of the story of when we first went to computer order entry at the hospital I was at, and we got a bunch of computers on wheels. We called them cows. It was very cute. We had a whole thing about make sure the herd stays together and feed the herd, plug them in, etc. Until we got some patient feedback, and the patient said she was really upset at our nursing staff and how we referred to our patients as cows, and we were taking the cow from room 2 and moving it to room 3 and moving the cow around the whole department. And we suddenly realized that they were in the rooms listening to us talk about cows. We were talking about the computers. They assumed because they couldn't see we were talking about patients. So cows became WOWs, workstations on wheels. Not as cute, you can't really herd them together and feed them, but nonetheless more patient friendly. So when we're talking about that, remembering you're on stage, the patients are always listening. And then the other one I'd like to highlight, or talk a little bit about it in a few slides, is rounding. Round, 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 and then round some more. And the thing to highlight is think about, so you probably, when you're status quo and the patients are flowing normally, maybe easier to round and keeping updated. But what happens when the bus drops off, when things unload and the wheels start to fall off? Do you have a contingency plan for rounding? Do you continue to round? Because this is when it's even more critical to make sure that you're rounding. Okay, the second one was nurses' concern to keep you informed about your treatment. And who remembers what the correlation was for this? I think we said it earlier because I got a couple. 96, yep. 96% correlation with would recommend. And some of the basics of this are explaining every interaction, explaining what you're doing. We use a lot of acronyms in our business. EKG, CT, not all our patients know what they're talking about. I use the example, I was talking with friends about ED. We talk about, we refer to it ED all the time. After the conversation, one of my friends came to me and wanted to know why I was talking so much about erectile dysfunction. I'm like, no, the other ED, emergency department. So it's making sure that we're using the right acronyms. Body language, we've talked about that, eye contact, and then demonstrating empathy, making an empathetic statement during the visit. Who knows what an example of an empathetic statement would be, or is?
If I had pneumonia, or I've had pneumonia before, I know what it feels like, or something to that effect.
Validate that they're feeling poorly?
Right.
Yeah, great, thanks. Anyone else? Any other empathetic statements you like to keep in your back pocket? I'm sorry you're here. I'm sorry you're not feeling well. Yep, great. So those are the basics. For concern, the other things that can help elevate you, I noticed you have whiteboards. in your patient room, so having whiteboards that are visible and large enough for the patient to read so that you can communicate using those whiteboards. Using the SBAR approach and doing bedside shift handoff, which I understand you do shift handoff at the bedside, that's excellent. And communicating effectively, and we talked about that using plain language as well as using teach-back methods. Okay, so this graph here relates a little bit to what Dr. Crane shared earlier, but the red box in the middle on the right, or it's your left, is how patients that waited less than 30 minutes rated their experience and if they would recommend. On the other side of the graph is if they were seen in greater than 30 minutes. And what it shows in the red box is if they were seen in greater than 30 minutes, if what was happened to them was communicated to them, then they rated their experience higher. Just further validating that, explaining to people why it's going on helps the experience. And this is helping keep them informed about delays. So the basics with this is, just being upfront about it. Having eye contact in triage, being upfront that, we care about them, we recognize that they're here, we know that we're waiting, and we're here to take care of you and keep you safe. The other strategies that help elevate this are you can post your expected wait times. Some do it online, some in the department. Follow a standard procedure for regular communication. I would say aid it. I know you've trained on here. My mission is I'd like to change aid it to made it, and the M would be manage up. Make sure that you manage each other up. When you're in the room, as nurses, we can say, you're really lucky. This doctor here has been here 10 years, does a great job, has a lot of experience. This person is really strong clinically, has a great bedside manner. Manage each other up. Manage, just like Dr. Hum mentioned earlier, when you're bringing them a blanket, when you're doing these things, manage them up. So you're managing yourself up. As well as managing expectations. Help overestimate the time so that you can over-deliver. Rounding, we talked about this, round, I get around, can't round enough, keeps the patients communicated with, helps them know what's going on, and it's everyone can round for whatever role, environmental services, patient advocate, tech, nurse, we all have a responsibility, physician, to round and keep our patients updated. So, in summary, to share a quote from one of my favorite movies, Bring It On. It says, the difference between good and great is practice. Let's keep the cheer and cheerleading. I would change it here to let's keep the patient in patient experience. So remember to focus on the patient. And if you could, my challenge, my part of the assignment comes with a little homework, is to take one thing from one of these groups. Staff care about patient as a person, dedicated to keeping the patient informed and keeping the patient informed about delays. And take one thing from one of these that either you're already doing and commit to doing it without fail every time, or pick up a new habit that you'd like to start. Does anybody work tonight? Who's our quick starts? Tomorrow. Okay, tonight. So your challenge is to start tonight. Pick something to start tonight. The rest of you at your next shift. One thing that you can do differently every time without fail with the patients. And then with that, I will turn it over to Dr. Hum, who now has the slide progression. You won't have the technical difficulties I did. Thank you.
Well, again, thank you guys for inviting us to your home. And I just want to ask a quick question to you guys. Do you guys know where you guys sit on your patient satisfaction? Who knows what your mean score is right now?
80.
It is 80. And so this
Here, use it. There you go. You see it? Just wave it. And you'll. There's a cursor.
Okay.
There you go.
Well, there you go. So 80.6 is 7. So at 80.6 of a mean score, where do you think that compares you to the rest of the hospitals in the country? 80.6. What percentile are you? So that is really pretty low. So right now you guys are probably about 15 to 18% percentile, that means about 80 to 85% of the hospitals are outperforming you as a hospital. And I know, and you guys know that you guys are performing high quality, great medical care. You guys are a tertiary hospital, all the sick people come to you because they know they're gonna get great care. So it's really about messaging and providing some consistency to the patients to change that score, and that score can change pretty quickly. So this is kind of like 85% of your patients, which is the polite patient. They just come despite the delay, despite the lack of courteousness, despite the lack of getting information. They'll just suck it up, and at the end of the day, they will just give you a 4. It's good care, but it's not outstanding care. And good care is not bad, but in Press Ganey world, a 4 out of 5 is the worst possible score you can have because that puts you at the first percentile. So at the end of the day, it's about moving these 4s to a 5. It's about setting some wows for every single person. So registration, nursing, physician needs to have these series of wows. So at our system in the Dallas-Fort Worth, we have about 19 hospitals in our system, and currently our overall system rating, we're at the 95th percentile. Our nurses are in the 95th percentile, doctors in the 93rd percentile. And that's because we have kind of a consistent experience for our patient, what's called the curated patient experience. We do the same thing over and over again for every single patient. So personally, how do I do and why I feel like I have some credibility in leading and discussing best practices is from 2013 to 2016, I've been in the 95th mean score, 90, maybe up to 96, 97. And in the last 2 years, I've been 100% because one additional thing that I've done, and that's my 19th step that I'll share with you. And the 20 steps that I will share with you, probably in 2013, I probably had 5 steps. In 2014, I had 10 steps. And in 2015, I had 15 steps. And it's just kind of iterations of trying to improve the patient experience. Clinical scenario, I think you guys should all understand this. 42-year-old female with chest pain, some shortness of breath, for 3 to 4 days, worse with inspiration, taking birth control pills. So most nurses and doctors would realize this is possibly a pulmonary embolus, a PE, which is life-threatening. So the first team, let's say it's Summit. They get the appropriate D-dimer, appropriate CT chest, it's negative, but the physician says up front, I don't think this is an emergency. I think you'll be perfectly fine, this is not your heart. He doesn't do any rechecks, and at the end of the visit, there doesn't provide any reassurance, just says your tests are normal, see your doctor. We know the quality of care in this aspect is great. Second team, down the road, it's a freestanding facility. The doctor and nurses are half the people you are. They only get a troponin EKG. They don't even realize that this could be PE. They provide Tylenol, Toradol, patient feels better. They do some rechecks, and the doctor does a good job with reassurance at the end, telling them that they've excluded the heart problem. This is, chest wall pain, this is muscle pain, and you're gonna be absolutely fine. So in this scenario, who gets a better score? The second team. Who provides better quality of care? First team. How does the patient know that? They don't. They assume that each of those hospitals is going to provide the same level of quality of care and the same expertise. And that's not true. And so what the difference is now how do you massage and how do you message the quality of care that you're providing? And that's kind of where you guys need to get to. So, Jody and Amy have talked about kind of flow metrics, safety, and most hospitals, groups, they focus on flow and safety. And so when we talk about STEMI, stroke, sepsis, there's always a nurse champion, right? There's a nurse champion that kind of shepherds the process and makes sure he hits the scores. Do we focus on patient experience at all? Do you see a coordinator focusing on patient experience in those numbers? So the first thing is really the emphasis for this facility is putting emphasis on the experience. So I am certainly not extroverted. I'm not a natural at providing this patient experience. I've had to learn these behaviors, and most healthcare workers are not extroverted, but these behaviors can be learned and can be very much repeatable. And it's a series of wows, for every patient that becomes the norm, and it resets a norm. And so what I thought was a wow 5 years ago, it's just part of my normal practice. And I keep adding a wow every year, every so often, to make that experience better for my patient and the patients that come to the hospital. And so you have to understand that these behaviors are applicable to every one of you. So as registration, you have to think about what one wow you can do for a patient that day. As a nurse, what 2 wows? And the nurse I kind of talked about earlier in this, before we started, bring that blanket and nurse, that's a wow. But you gotta kind of take credit for that and script it and message it to where the patient feels the wow. So that's really important to understand. So my 20 steps, and again, this is an iteration. I don't expect any one of you guys to have 20 steps memorized, but you should have 3 to 4. So the first thing I do is I know where my blanket warmer is in my hospital all the time. So I know I pass by the blanket warmer, get a blanket, and bring a warm blanket to the patient. I knock all the time to make sure I can come in, and I introduce the patient by name, myself, and shake everyone's hand in the room. The most important person to greet is the mother or the wife or the daughter of an elderly patient. Because guess what? Who fills out that survey? It's one of those 3. It's not the guy, for sure. Guys are horrible at filling out surveys. And so that mother or that wife, if they have a good experience, they'll fill it out. If you don't communicate with that mother, wife, or that daughter, you're going to get a 4. There's no doubt they'll give you a 4. So you guys have to focus on the audience and who's important. Obviously, you got to take care of the patient, but you got to focus on who the audience is. Sit down. That's important. Just, sitting down, thinking they have more time with you. I always apologize for the wait. And so as Jody Crane saw my list, and he has his kind of list in his mind of what a high-performing doctor is, those 2 lists just aligned. And that's why I'm here kind of talking, because these repeatable behaviors are the typical norm for all high performers. Not just apologizing for the wait, but apologizing for their bad day that they're here. Who wants to be in the ED? No one. So it sucks to be in the ER. So you gotta apologize, Ms. Smith, I am so sorry for your wait. Thanks for being patient with us. More importantly, I'm really sorry that you're here today. This is not much fun being in the ED. That lets their guard down, and you can now move forward. And think about this. If a patient's been waiting for about 3 hours in the waiting room, my 20 steps, it's going to mitigate that wait in the waiting room, and I'm still going to likely get a really good score by what I'm doing. I always have closed-ended questions. I can still run circles around my colleagues because I have closed-ended questions when I do my history of present illness. If I give open-ended questions, patients will ramble. But so with my closed-ended questions, I do allow one question, and that's to, the patient or to the most important person in the room. What do you think? What information would you like to give me that we haven't discussed? So I give them that one opportunity, to give me more information that I may have missed in my closed-ended questions. And that seems to suffice with that one open-ended question. As Jody Crane says, don't tell them that you're not sick, you don't have an emergency. They're there because they think they have one. And as nurses, doctors, we kind of minimize people's complaints. In fact, you've got to do the opposite. You've got to kind of treat any trivial complaint with respect and curiosity, because you will eventually get burned when you don't. Let them know your recommendation on the test and engage them to be part of the decision making. So Ms. Smith, I'd like to get a chest x-ray, some blood work, give you some IV fluids, some blood pressure medicine, and get you feeling better. Is that okay with you? Explain what test and time frame. Ms. Smith, this is going to take about 3 hours to get everything done. If you were being seen by your doctor in the office, this probably may take a week. So I know this 3 hours may seem like a long time, but you're going to get everything you need in these 3 hours. And likely the workup's going to take 2 hours. So overestimate the time. And so under promise and over deliver. And then lastly, are you missing something? Ask the patient or mother, am I missing something? Let them know that you're concerned about their comfort. And offer pain medicine all the time, even if it's just simple Tylenol. Would you like some Tylenol for that headache? Would you like some Tylenol for that ankle sprain? Would you like some Motrin for that finger? We want to make sure you're comfortable, which is one of the press-gating questions, comfort. And then lastly, tell them that you're going to take good care of them. Look them in the eye and say, hey, Ms. Smith, I'm going to take really good care of you today. You're in really good hands with a nurse and myself. We're going to take really good care of you. The middle, that patient with kidney stone pain, you're giving morphine, Dilaudid, you're giving Toradol, they're going to feel better in about 15 minutes. Go back, claim that little win for your team. Ms. Smith, I'm glad the nurse gave you that pain medicine. I'm glad you're feeling better. I'm glad you're much more comfortable. We're still waiting on your blood work and CAT scan. I'll be back. And then always reintroduce yourself. Each and every time you knock, hey, Ms. Smith, Dr. Hum again. Hi, Ms. Smith, Dr. Hum again. They will hear your name and correlate you with a better score. Print labs, when results are available, I always share those results. I kind of check those and then give it to the patient. It's a kind of another safety check, because sometimes if you just glance on the screen, you may miss pertinent labs. So that's kind of a hard check for me, is giving patients, and I'll check what may be circle or check what's abnormal. Exit interview, hard copies of radiology reports, the rest of the labs. Ask what questions you can answer, especially addressing the family members, because they're the audience. And the last thing I do is, this was probably a later iteration of my 20 steps, is, do you feel safe going home? I might not ask that on an ankle sprain, but on every other patient, belly pain, chest pain, headache, do you feel safe going home? It's an important question to ask. Last memorable moment, and this is what I've done over the past 2 years consistently on every patient, giving me a 100% mean score, is I ask the patient, or I tell the patient, you might have more questions when you leave, it's often difficult to get in touch with your doctor. Here's my cell phone. And I write it down on a piece of lab paper or the CT report. And I say, please text me if you have any questions or concerns over the next 2 to 3 days. And that just, solidifies my visit with that patient, and kind of just that closure and that curated experience I've given to that patient, is going to get you. First of all, it makes the patient feel great. The smile, the look, the surprised look makes me feel better. And it turns out to be a very good visit. And previously, I used to tell them to call me. Well, I stopped doing that because I did get an occasional call, and I didn't screen them, so I just picked it up. Now I have them text me, because now I can screen every single text before I respond. So just different iterations. And I don't expect you guys to give your cell phone numbers out, but just consider linking it to a WhatsApp number or a Google Voice number. And occasionally, if you have a good experience, just give out that number and see what happens. How often do you think they text me back or call me?
Very rarely.
What's rarely?
Well, like twice every 3 months.
Okay, so out of 100 patients, probably two of every 100 patients I see. So if I'm seeing 25 patients in a shift, maybe one person will text me in that shift. And it's usually a simple text. And the patient feels so much safer going home. We all encounter that patient that says, well, doc, I don't really want to go home. They don't need to stay. But that patient is a little bit worried. They don't know what to do at home. They don't have as much resources or help at home. They're scared. I've learned that when I give my cell phone out, they're more apt to go home because they know they can call you, text you immediately, and you can send them back to the hospital. It's a safety issue too. The patients feel safe when they have someone to contact in their in that illness. So just a few case studies. We've had many doctors that, number one, they just are overworked. They see way too many patients. It's too busy. Acuity. They see a patient, it's just another number. It's room 8. They don't even know the patient's name. And by kind of going through these 20 steps and lastly giving the cell phone number out, it's incredible kind of the impact you will have with your patient and the connection you will have. And once you have that connection, your day gets better. It gets better and better and better. And now, this person went from the 33rd percentile, who's not happy, going to the 98th percentile and sustaining it for the past several years. 2 years from December 2016. Because now he's happy. He's still seeing the same amount of patients, but he's happy. Ron Tanaka, November 2017, same similar story. And we just have a lot of these stories of success when people come back and have that connection with patients. And in all 4 of these physicians, and what they end up doing for themselves is they've created this experience in their mind that they're going to do all the time. So it's a kind of this curated experience that they provide for their patient. It may not be the same 20 steps or the same experience that my patient gets, but it might be very similar, but they do this very consistently. They message it the right way. And they all strive, they want to be 100% all the time. So I can coach doctor to doctor, nurse to nurse, but at the end of the day, that's such a heavy lift. Most importantly is, how do we lift the entire facility so that one doctor doesn't have to do it differently than the rest of the people all the time? And that's where we've had some success in our systems about a physician-led patient experience committee. And one of our doctors was struggling. Single-digit satisfaction scores, not doing well. His dad was the ER doctor, got burnt out and quit emergency medicine because of Press Ganey. All right? And that's, a lot of you guys probably feel that way. But this guy was 28. What was he going to do with a medical degree, you know, and was he going to quit because he didn't like Press Ganey? He figured out that it's not going away. It's not going away. So what we did was we made him the leader of this patient experience committee because he was a naysayer. 2018, after 2 years on this committee as the leader, his scores, he gets it. Top decile, top 2% of the country, or top 5% of the country, his scores have dramatically increased. Dr. Lowe on that far right, we actually presented him as one of our emerging leaders of the year because of his dedication to this committee and floating all boats. This is a pictorial of how they would look at their data. So in this column, you can see, you know, wait time to treatment area. They didn't do well in this section. So what, as a committee, from registration to nursing to physician, how do they solve that problem? And so in that committee, they break down certain areas of problems, and so they know where to start, where to fix. Because if I were to ask you guys, how do we fix your score of 80%? No one would know. So the most important thing is data analytics and understanding your data and where you guys are sitting. So after this committee, not only did Dr. Lowe's numbers go up individually, but the hospital went from the 38th percentile to the 85th percentile after 2 years of work with everyone in all disciplines involved. This is a great slide for nursing, registration, and everybody that's involved and touches the patient. All these departments now have hit max. It's a success for the whole hospital, not just for the nurses or doctors. My final 20th step that I've learned, now that I've kind of figured out the other 19, is the power of yes. And what do I mean by that? If you say no from the start, it polarizes, it creates defensiveness, and it shuts down collaboration. So someone in the audience, give me a tough question that you get all the time from your patient that you always say no to.
The abdominal pain that comes in, asks for a drink or something to eat.
Okay, so ask me.
Can I get something to drink?
Yes, I know that you're really thirsty, but until we make sure you don't need surgery, I can't do that yet. But what I can do is just give you a swab. The classic thing is, doctor, hey, I need 4 milligrams of Dilaudid. Who has not heard that? And the physician goes in, you've been here 20 times this past 6 months. I'm not going to give you Dilaudid. What do you think is going to happen with that interaction? Yeah, he's pissed already. You've kind of labeled him. What I would do is, hey, Mr. Smith, I know you're in a lot of pain. Let me see what I can do about treating this pain. Let me look at your chart and figure out what I can do safely. So I know with my heart that I'm not going to give him Dilaudid, but I'm not going to have a confrontational no immediately. I'm going to go back, check on a few other patients, come back and say, hey, Mr. Smith, I see that you've been here several times. Unfortunately, because of the state laws, we can't give you any more Dilaudid. I can give you 2 Vicodins right now. I can give you some Toradol. I know that may not help as much as what you normally take with Dilaudid. I'm sorry, I can't do that. Here's my cell phone. I know that I can't do very much for you, but if you do have a question, send me a text. I'm sorry I can't help you today. He's pissed that he's not getting his Dilaudid, but he's not really that pissed at me. He's never had a doctor give out his cell phone number in case he had a question. Is he ever going to text you? Is this person going to fill out a survey? Absolutely not. And studies show that people that have pain, chronic pain, that are somewhat dependent on opiates, they just don't fill out surveys. So there's this misperception that my scores tank because of these patients. They don't fill out surveys. But you just have to be respectful to these patients. So what we would recommend, is we don't want to climb uphill one by one, doc by doc, nurse by nurse, but setting up this patient experience committee with physicians, administration, someone from the C-suite, nursing, registration, radiology, and lab, and collaboratively fix the problems yourself. You will be amazed at what you guys can do yourself than having Dr. Crane or myself here. Because when you guys fix the problem, you guys will enjoy the success and you guys will own it. So you're really setting new standards for behavior. You're also increasing the emphasis and awareness of where you need to be as you guys set emphasis on stroke, STEMI, sepsis. Same thing, sets of emphasis on this patient experience. And sustaining that 10,000 hour rule, at some point, your facility, your providers will be experts at this. Doesn't take that long. We obviously discussed the nursing rounding callbacks. You won't need that if you do this other part right. So some graphs we provide our physicians may look like this. This is kind of done by individual physicians. Top is green is really good, bottom red is bad. So we can isolate our physicians and know who's underperforming. This is our best graph, and we share this in the patient experience committee, is which physicians provide the biggest and best impact to the scores at the facility. So in this one, Dr. Tanaka, his scores are so good that he provides a 31% positive impact. And so we celebrate the success of the physicians and departments in that committee. We also have a negative impact. We don't share that as much, but we talk to the physicians, counsel them, and we know that there might be 4 physicians that contribute negatively and hurt the overall score so much that if we raise their scores, the whole department does so much better. So in conclusion, the curated patient experience is through education, individual practice, and often with the committee, establishing the new norms of behaviors for the department and the correct messaging to your patients. We have to practice this. We have to extend this not just to the patient, but who's going to be filling out the survey and the family. That's important, is kind of extending this experience to the family. Better communication really provides safer care, becomes second nature, and easy to deliver. Again, the emphasis and awareness is huge. Jody, you want to take this last slide?
Yeah, guys, so thank you so much for joining us today, and I'm sorry we went a little over, things got a little hectic in the front end of this, but I know you've heard a lot of information here, and I want to boil it down to just a few things you can walk out that would be top of mind. One is, remember, we are not in complete control, but we control a lot of setting expectations for patients and managing their perceptions. We drive a lot of that. You guys are on stage. The other thing is, we talked about the benefits of working on patient experience. I think the number one is your experience will improve as a provider. And I showed you guys that chart. When we were at our worst in my ED, I told you I'd come in, there'd be 50 people in the waiting room, and you'd literally come in that side staff entrance door, and the night shift would be leaving, and I'd be coming, and they'd go, don't go in there, don't go in there. And you're like, wait a second, do I have a choice? I mean, I'm sure you guys do that same thing. And I knew I was going to get yelled at by every single patient all night. And so my interaction with patients was, the first few I'd fight back, and then I'd get kind of tired of it, and I'd just sit there and I'd let them yell at me until they were done, and then I'd say, okay, you're ready to be cared for now. And so I got into this confrontational kind of way with patients, and it was a really bad place. But as we started to improve, both on operations and kind of, as I kind of matured as an individual, flash forward a few years, and I was whistling on my way to work because I knew it was going to be a great night. And that's what I want to impart on you guys, is when you work on this stuff and you have happy patients, it's going to make you happy. The last couple of things, I want you guys to walk out in your next shift. Anybody working tonight or today? Okay. I want you guys to walk out of here and just take a couple of these things we've taught you. Just pick one. And Lawrence gave you a list of 20. Start with one today. Just pick one thing and hardwire it. And the easiest one to start with is what? Apologizing for the wait. No additional effort, no additional anything. Once you got that hardwired, pick up another one. Pick up that do a non-medical gesture piece. And just pick up one a week, one a day, one a week. Just practice it until it's kind of second nature to you. And what you'll find is your experience walking out of that ED is going to be better. Okay. And to me, it's all about. We don't need to bend over backwards for patients, but we certainly want to work in an environment where we're happy and we're providing great care. And I think you guys provide the great care. I want you guys to be happy too. So thank you guys very much, and I hope this kind of launches you on your journey here. We'll be doing more work with your leadership team. Thank you guys.
Good morning, everybody, and thank you in advance for adjusting your schedule. Sorry for the delay, but most of us are nurses probably. One of our competencies is go with the flow. So can everybody hear me okay? Maria in the back, can you hear me? Okay, I'll stand there. All right, so I know a lot of you have already been working on a lot of patient experience work. Show of hands, how many of you are really the experts for your unit in patient experience? Anybody? Kinda? Right, you've been Studerized, as we say it, right? Everybody's had some Studer stuff happening. What are some of the other things? Anybody have other things they're working on, or are you usually using Studer? Attention, attention. This is the interactive part. So I joke a lot. If that offends anybody, just raise their hand and I'll stop, but it kind of helps me get through the day. So by way of introductions, I'm Tracy Gallioni. I'm an employed consultant with Team Health, and we're a group of physicians and nurses. I work for Dr. Crane and with Amy and Dr. Hum, and we go about the country and get to help people and support you in whatever way you need. And so the ask was to come share some information on patient experience. And I know you all have been doing a lot, so there may be things that you're like, oh my God, here we go again, and there might be a couple of pearls that I've picked up along the way over the course of my leadership time or improvement time that can help you. It'd be great if it could be interactive, because that makes it more fun. And then this is geared towards physicians and nurses, case managers, and so it's framed in a way that you would be teaching that group, so you can take any of these slides back when we're done and share them with your team as you wish. So as I said, the purpose, we're here evaluating, just kind of getting the lay of the land, if you will, and understanding what you all do. Offer some opportunities for improvement, and then the most important part is the sustainment, right? Because we don't want people to think it's another flavor of the day, that we want to make sure that our team members realize that as leaders, we really believe in all of this and we can live it every day. And so we'll just go over the pearls that I brought, and really if you have questions, please stop me. It can be very casual.
You feel like you're working?
Yeah, that's not we all look at things through different lenses, and so often when I'm just working with a group of doctors, you know, I realize that some of them might think, oh gosh, this again, or are kind of cynical. They might even be angry about having to come and talk about this again. Some are excited and really want to learn things. So know that your team is feeling the same way. They're kind of uncertain about how do I do this. You know, it doesn't feel right. They're telling me, introduce myself and manage myself up. And to some people, like me, that doesn't always feel very comfortable. So know that we're coming, we understand that everybody's coming at it from a different lens, but we're all from healthcare. We came into healthcare for a reason, right? Something drew us to this building, to this profession. So can somebody share with me why they went into healthcare? I will just start to call on people, so if you volunteer early. So sir, up front, why did you go into healthcare?
Funny story.
We love them.
I was dating a girl whose father was a pulmonologist, and he wanted to know if I wanted to do respiratory care.
Awesome.
Are you still with the girl?
That's a true story. What else? You in the pink shirt in the back. Yes.
My father was involved in healthcare, helped me get into healthcare, and I worked in transport. I like tracking people, building numbers, and it's always tracking people.
Great. So even though the girlfriend's father gave you a reason, there was some pull, right, that you enjoyed the help part of people?
Yeah, I was an EMT at the time, too.
Yeah. So great stories, and we probably all have one for sure. So why is it important? You've heard this also. This is just more of a sync up and get us all in line. You know, but earlier, some of you may have heard Dr. Crane talk about, you know, people will sue you less, but it's really about trust, right? If you provide a good patient experience, people start to trust you. They feel comfortable and confident in the care. You know, you have, I understand, a joint commission here today, so they're probably looking for things, right? And Mont Joint Commission, okay, so great. Sorry.
Rumor control.
Anyway, so, and also, when you make a patient feel good, doesn't it make you feel good inside? Like, when you even pass somebody in the hall and say good morning, doesn't it kind of make you feel good inside, right? So there's a real reason, and to teach your staff that is really beneficial to the patients, to their families, because they start to relax, right? This is a friendly place. And then, you know, the regulatory, the pay per performance. So does everybody know about pay per performance, right? Money attached to it. And then just making that emotional connection. So just to sync us up, I'll go very fast, but you know, the value-based purchasing, when HCAS started 8 or 9 years ago, patient experience was a low chunk of the pie. Now 25%, right, is at risk. That's a lot of money for a hospital this size. And if you get penalized, right, that's a big deal. So we got to do it all right. It's more than just about clinical care, and you'll hear me say that several times, because most of our patients think that we're giving them good clinical care. They can really assess us on all the other stuff that HCAS asks them about. So as far as the survey, I'm going to skip over this, but just know that communication over all the domains counts for 36% of that. So of those 25 questions, 7 are demographic, and the other 36% of them are related to communication. So we got to get it right. These are your results. I doubt that you can see them up there, but I wanted to pull them to see. So some opportunity, right? You're a 3-star. This is a great place. There's no reason why you shouldn't be a 5-star hospital for patient experience. And then just a reminder, we all get really excited, or at least I do, about what can we do to make it better. There's definitely some questions you can't say, right? So in the beginning when HCAHPS first came out, we were doing that, can you give us a 10? If you can't give us a 10 on the survey, let us know what you can do. Do we always take care of you, right? You're biasing the survey by doing that. So make sure that when you come up with these countermeasures for patient experience, that you kind of check the Press Ganey has a great list of all of them, and help the team with that. Because you don't want to stifle their improvement, but we want to guide them in the right way. And then, as I said earlier, so, you know, your rooms and your units are pretty open, or at least the ones I've been on, and the doors to the patient rooms are open. Who's ever been a patient laying in a bed? So for those of you who have, you can hear everything. And when you're laying sick in bed and don't feel like watching TV, you can hear everything, whether you're in an ED or in a patient room. So that counts for what they hear you say in the hall. So yesterday, Amy told about in the beginning with computers on wheels, and we used to call them cows. And patients were starting to say, what? They're talking about us, that we're a cow in the room? So they quickly switched to workstations on wheels. And they don't know what patients you're talking about, right? So if you're talking in the hall about a different patient and you say something, or your staff say something negative, you hear it, you think it's about me, right? Or if you can't hear everything, you wonder, your mind wanders in that room. And then it's how we make them feel. So remember, that's more about what they're judging us on when they're thinking about the survey. So as I said earlier, it's all about communication, verbal, nonverbal. You all have AIDIT here, and then a non-anxious presence. So it's busy here today, right? Busy day? So what does a non-anxious presence look like to you, AJ?
Not rushed, taking your time with the patient.
Mm-hmm. And that's hard sometimes when it's busy, right? So as leaders, when it's busy, it's our job and our duty to go about and make sure we keep things calm, the on-stage, off-stage, and making sure that we have a non-anxious presence so our team members can have a non-anxious presence. Make sense? And if you've ever read the book Failure of Nerve and go on YouTube and look at the video, there's a great little video, 5 minutes, that goes into a little bit more detail. So, and then plenty of studies that have strong clinical evidence that say if we get the experience and engage our patients, that then the clinical quality is good as well. So I'm trying to give you just a little information about the why. And then, you know, this is a more of a physician slide, but I think it applies to everybody, right, or to all of us. We want to be treated with dignity and respect. Healthcare concerns are addressed. You're easy to talk to. So what does easy to talk to look like from a nursing standpoint, patient to nurse or doctor to nurse? What do you guys coach your team members in how to make an emotional connection with the patients?
A lot of listening skills.
Listening.
Mm-hmm. Giving them the opportunity to ask questions without interrupting them.
Yeah.
Concentrating on them as a patient and not a procedure.
Great. Anybody else have any pearls?
Well, you also just want to look approachable. You want to go into the room with a smile. You don't want to look like you're in the middle of something and the patient isn't your priority. You know, stepping away from behind the computer, making eye contact with the patient so that the patient understands you're there for them.
Mm-hmm. Right. Yes, ma'am.
It's the on the bottom, willing to spend enough time. It's the perception that you have that openness, and so our code has always been to sit down.
How
Don't
often?
stand at the desk, don't stand at the door, don't have one hand on the doorknob. Come in, sit down. By sitting down, you are communicating immediately that you're ready to listen, even if it's for a minute.
And really, if you sit for 30 seconds to a patient, it feels like 2 or 3 minutes, but it's also less intimidating, right? If I'm not standing over you and taking the higher level stance, then I'm coming down to your level. So great, all great pearls to share with each other. So in the inpatient world, or in general, we talk about the beginning, the middle, and the end. On the inpatient side, we have lots of beginnings every day, right? So it's every encounter, every day, at shift change, at admission. So we have lots of opportunities to do these things on inpatient. Not that the ED doesn't, but our patients generally stay on inpatient a bit longer. So what is your welcoming ritual? So I like to ask staff this, physicians this, like, what do you usually do? And, you know, we get a variety of answers, and these are some tips. Some of you have just mentioned a few of them, but, you know, to really get standard process in place that feels comfortable and people can make it their own. So, do you have, with AIDIT, you know, it's the acknowledge and acknowledging everybody in the room. We often coach our physicians to do some type of touch. So how many of you, when you do leader rounding, always shake the person's hand? Right? Yeah. So that's awesome. And what other things? Anybody have things that over time they've kind of made their own and added to some of these, like their name, who you are? What else? Anything special that you do? So the ED talked about the non-medical gesture, and they talked about, you know, it's almost like a delighter, right? They aren't expecting their physician to bring a warm blanket to the room with them or get them water, things like that. But some patients, you know, we tend to go in and, you know, hi, how are you, and get right to it. But remember to bring something non-medical to continue to lower their anxiety. So maybe you know that they have a cat at home or a dog at home, and ask how they are. When's your daughter coming again? It's those small things that help them get in the mood for that visit, if you will. So the one I often see is, I know we say we commit to sit, or to sight, actually, because I have a typo up there. But the acknowledging all the visitors in the room and making sure that it's okay to continue to talk with those people in the room. We're doing multidisciplinary rounds at the bedside, a trial at a site recently, and the team forgot, and when they left, the lady goes, oh, and by the way, I'm the wife. So, I mean, and you know, she's gonna be the person who fills out the survey. So they had some immediate service recovery to do, and they went back in and apologized and said, you know, explained to them what they were doing, that it was new to them. And she was very understanding. Someone else might not have. So the one thing that we like to talk about is the blameless apology. So you wanna make sure that you teach your staff, it's okay to say, I'm sorry to hear that, or I'm sorry. You know, we know that patients wait a ton in the hospital. I mean, we make rooms called waiting rooms, you know, and nobody likes to wait. Oh, and that was a joke, by the way. Thank you, gosh, the delivery. Anyway, but, you know, make sure that you know, apologize for any of their concerns, even if you didn't do it, right? You just apologize that, gosh, I know you had a long wait in the ED, I'm really sorry, I know that was hard, but I'm really glad I can be taking care of you now. And what's the resolution? What can I do to make it better? What would help you? You know, so really that open-ended question, because most of the time when people get it off their chest, it's over and done with, right? And so then they can move on, and you can have a great visit with them. If you can't do what they've asked you to do, make sure you let them know, right? It's still AIDIT again. Explain that you're gonna escalate it and then circle back, right? Did Susie take care of your issue? I remember that from yesterday. And then show empathy and anticipate patient anxiety. So again, those open-ended questions are what really help. Often I see people say any questions as they're doing the backslide out the door, you know, or you can see their nonverbal communication is like, oh, please don't ask me any questions, I'm really busy today. So make sure that your team understands that it's, you know, what matters to you most, and it's the pause. So sometimes I teach the doctors, count in your head, count to 5, count to 10, whatever you need to do, and make eye contact through that to make sure that the patient understands and that you're inviting the questions. You want the questions. So, and then you'll see this, I put it in several slides, always under promise and over deliver. So if you know that lab turnaround time is, I don't know, 3 hours, say, tell them it's 4 hours. Then when they get it back in 3 hours, they're delighted, right? It's those simple little things that really make a difference. And then one of the ladies in the back mentioned this, how important listening is to communication. I always like to say listen with your eyes and your ears, because the person's nonverbal communication is going to give you a lot of clues. And so teaching newer staff about that takes some time. Open and relaxed body stance. So like you can probably tell I'm not that comfortable being behind the podium. I keep walking out because I like to be out here. If I was confident I wouldn't trip coming back and forth on this podium, I would be down by all of you, so for sure. And you know, it's reflective listening, so you can ask that, so what I think I heard you say was, and give them time to restate it, and it just lets them know you were really listening. The same with the next day. If they told you today that they're really worried about their diagnosis of, you know, chest pain, the first thing you can say is, well, yesterday you told me you were worried. How are you feeling today? So it's really those small things to do to let the patient know that you really know a lot about them and you heard what they were saying. So this is an interesting one. There's a number of studies done, but how long do you think it is, and I think this can apply to any discipline, but for physicians, how often, if they started asking a patient a question, how long before they interrupt the patient? What did somebody say?
6 seconds.
6 seconds. Who else has a guess? Come on, be fun.
They almost don't get, I would suspect the patient doesn't even get the first sentence out when they get interrupted, maybe
I
2
heard
seconds.
a 3, a 6. The average is 11 seconds, and with a tail of 252, so there was a good listener in the study, and that other tail of 2 seconds, but average of 11 seconds. So, you know, and that was from them talking, so you can only imagine the body language of, are you going to be quiet? Because I got a lot to say and a lot to do. So think about that. What is the ritual you use to really engage and make sure people are listening, or you're listening to them? I know it's a lot, but sometimes we have to listen. I was with a physician, and he's like, this lady kept going on and on and on, and I just really didn't want to listen anymore. And I'm like, well, you got to get a little more savvy about redirecting her. But yeah. So transitioning then, so you do all these things in the beginning to kind of set the stage, to lower the anxiety, to get the patient to trust you, and then in the middle, so every patient every day, and some of these we've talked about. But again, collaborative rounds, so I don't know, on the floor, do you have an expectation for your nurses to round with the physicians? Are there any physicians in the room today? Great, great. Do you take the nurses with you when you round? No?
Only if they want to.
Only if they want to.
Have to volunteer.
So I'm really a strong advocate for that best practice of it on many fronts, right? The nurse then isn't calling you later. You don't have to call them and go find them and repeat. You know all that, but from a patient perspective, and this is an aside, but as I guess it's called the sandwich generation, so I'm taking care of my older patients now and have a different, or my older family, have a different lens of when that happens, it makes the family feel so much more comfortable. So much more comfortable that they see the team working together. It's, you know, I practiced in an environment where that was just the way we practiced for years. And honestly, I didn't know until I left that there was another way to practice. And when you don't see it that way, when it doesn't happen, it feels a lot different. So something to think about. And then you can align expectations together, always engaging the patient and family in the room. You know, I had a chance to round on one of the units this morning and watch the rounds. They were good in many ways, but I think it's human nature sometimes to forget there's a patient in the bed, and then you start talking about she and he, and they're right there, right? And so you gotta remember, how do you engage them in the plan and set goals with you? Again, under promise and over deliver. If we're gonna be back later, how much later, what is the plan? You know, and then really, here's where you can, if you're rounding together, it's an awesome opportunity to manage up. You know, and just say, you know, we're rounding now, but Amy is a great nurse and she and I communicate all day together. You know, so there's awesome opportunities for that middle part. Mindfulness, patience, and presence. So I think it is the pause before entering, knocking at the door and waiting. I notice the rooms are pretty open here, so closing the door because it's noisy in the hall, it's super distracting. Shut off the TV, you know, ask them for permission to do those things, but for sure do it. You know, sometimes on a busy day, I just stand outside the door and maybe just take a deep breath and then enter. And it's, you know, a great thing to teach your staff about mindfulness, and really, because patients pick up right away if we aren't in the moment, and those are exactly what we don't want to happen. Make sure, again, your staff convey that non-anxious presence. They aren't telling staff, oh, we're short today, we're busy today. Those are those never words that we should hear in the hallway or in the patient room. Those are off-stage break room comments that you don't want the patients to know, because they start to get anxious. They don't want to, there's a big population of older patients that they don't want to bother anybody because they know the girls are busy. And so we want to make sure that we don't convey any of those things. And we talked about managing up. So does anybody, as you're rounding, have any tips for how you manage up when you're in the room? Yes, ma'am.
Well, first, I think one of my pet peeves is when one discipline puts down another in front of the patient. And I know why they do it, because they're getting heat. So let's say somebody's waiting for pharmacy, they're waiting for a new medication, and the patient keeps saying, well, when am I getting new meds, when am I getting new meds? And then so they're feeling heat, so they kind of deflect, and they say, well, that pharmacy, this always happens, we're always waiting for our medications, they never come on time. That is my pet peeve. We should never, ever put that in the department, ever.
So how do you all mitigate that?
Well, first of all, don't do it. And then you say, well, you know, I'll apologize, and I'm going to call them, and I'm going to follow up for you, and I'll see, I'll communicate back to you. Whenever I get some information, you'll be the first person to know.
Yeah, absolutely. And then having that conversation, right? The follow-up, the respectful, the candor with respect to that person who is saying it, so they understood. Because they don't do it, I don't think anybody comes to work meaning to do those things. It just kind of slips out, right, in the heat of the moment. So yeah, that coaching. You know, I love doing bedside shift report, nurse to nurse, because it's an awesome opportunity to manage up the person coming on shift and the person going off shift. You know, if there's opportunities for nursing in the room with the, I don't know if you call them patient care techs here, but your assistants, you know, to really say what a great job they are, what a great team, and really get that feeling so it feels like it's in everybody's bones to appreciate each other, and patients pick up on that. And so just keep that in mind, that every opportunity in front of the patient is some opportunity to manage up, even if it's food service or, as you said, pharmacy, things like that. More things for in the middle. We talked about having a seat already. I saw that there's chairs in the rooms, hanging on the door, so it's great. So there's really no reason that somebody can't sit in those rooms unless, they're taken up for family. The other thing, when you're doing your 4 Ps for hourly rounding, I like to include the environment. So if the chairs are full of stuff, right, it isn't very inviting when the family walks in to sit down, or a doctor needs to sit if they have to clean the room. So getting those sensitive eyes to the environment is really helpful. And I don't know, do you have the Commit to Sit campaign here? So it's, kind of the buzzwords from places are doing that, just like the no pass zone and things like that, to get everybody in that mindset. Some additional, we talked about committing to for commenting on the previous day. One thing I see in our technological world is the phones come out, or we just sneak a little peek in the room, and things like that. So we ask our doctors to put the phones on vibrate. If you're the person on call today, or the quarterback, things like that, we just ask them to explain that, I'm the lead physician today and I may get a call, or if you're expecting a call, I'm gonna step out of the room to take the call, but I will come back. And so that, again, lowers the anxiety, but for everybody, the phones should be, unless you're, waiting for an urgent call, it can wait the 2 or 3 minutes while you're in the room. Yes, ma'am?
We document our rounding on an app that's on the phone, so I just always go in and I just let the patient know. I have an app on my phone to accurately capture all your responses to the questions that you're giving me. So I just want to let you know that while I'm on my phone, it's just so I can write down everything that you're telling me about your experience. But we have a live rounding app that when I go in the room, that's what I have open, and that's what I'm asking and writing in, so.
Yeah, you've done a great job explaining that. That's awesome. Because I know in the beginning when iRound and Point of Care started, they recommended using a tablet because patients were feeling that the phone might not be as secure as other things. It's just a feedback they were getting. So I think your explanation is awesome. Yes, ma'am?
What scripting would you suggest for the nursing staff who do get multiple calls on their phones, either to respond to another patient, or if a physician or another department has contacted them? What scripting would you suggest or recommend for them to use with their patients so that they don't feel like, there's anxiety when they see them reaching for their phone maybe multiple times while in the room?
I think there's things, my mind goes right to why are we getting so many calls? Like, what can we do to anticipate those before we go in the room, or, work upstream so that our questions get answered earlier. But I think just explaining that, it's not my cell phone, it's my work phone, and that I will come back. That seems to be the thing, because sometimes when we take a call, we never come back, and then the patient's left wondering what was supposed to happen here. So really, the explain part of, acknowledging that it was an interruption, and then explaining how long. So if you're gonna be on the phone with the doctor for 10 or 15 minutes, say you'll be back in 20, and then they'll be delighted. So really, it's that overpromise and underdeliver again, in a way that makes sense for them. I always advocate for the open-ended questions, for sure. So it's really easy to flip those questions around and just start with what, where, who, how many as the first word, and it just naturally becomes open-ended. And then the strong finish. So if this is the end of your visit, confirm the plan again, get the patient in agreement. If they aren't in agreement, how can you adjust that plan? We really like to use teach back, so those new things that are happening of the ask, tell, ask. So really, our patients, our families, they've had experiences. It usually isn't their first experience. So for example, if you have a newly diabetic patient, you can open up with, tell me what you know about diabetes. So it already lowers their anxiety that you're acknowledging that they're smart people, they know things, right? And then you can say, oh, I heard you say this, you had a mother with diabetes and you know a lot. I'm gonna tell you some things that I know. And then you can ask them again, now, do you understand? What else do you need to know? So the ask, tell, ask. Because it really starts to build confidence in the patient that you really are acknowledging them as a collaborative partner in their care. And then discharge timeliness. So what's the goal here from the time you get the physician's order to the patient departs the building? So earlier, Dr. Crane mentioned that some of our big corporate clients have some best practices for the ED. Some of them are now asking, their goal is 90 minutes. So from the time the physician writes the order to the patient departs the building, because they're sort of reserving those rooms for the next patients that are coming in. I would say across the country, best practice is 120 minutes. So if the physicians write an order at 9, you should be starting to plan that by 10 o'clock, the patient's gonna be gone, EVS can clean the room, and by 11, you're gonna have free rooms. And some of our sites on days like this where it's busy and beds are at a premium, 2 by 10. Every unit, 2 patients depart by 10 a.m. And so that you start to free your capacity early. And I can give you examples offline if you're interested in that. Because patients, when I round independently, tell me 2 things. It took me a while to get to my room, and it took me a long time to get out of here. I've been waiting, I've been waiting, I've been waiting. And you know, the discharge is our last opportunity to wow them, delight them. So it's really important. And so do you have any I should have asked, besides the goal, do you have a discharge time of day goal? So that.
We usually use, out by 12, and we're running right now about 27, 28% of our patients with active orders available as well. So under delivering on that.
So that's a great one to work on, because if you work on that back end process, you're going to start to free your ED, and then you're going to have more delighted patients coming up to the units because they haven't had to wait as long. So again, I won't go through every one of these, but just again, the what questions do you have, the under promising and over delivering, and then making sure that you ask them, have I explained everything thoroughly for you? And then again, get their agreement and the plans so that they aren't going to their PCP and talking about the experience in the hospital in any way but delightful and encouraging to their PCPs and to their family and the community. So I want to just spend the last few minutes going over just some general tips, and then I'll take any questions, any comments, any feedback that you all might have. So my background is with lean performance improvement, and one of the biggest things in that plan, do, study, act cycle is sustainment. Because oftentimes we start great things and then we implement them and then we start another great thing, and then you turn around and you go, I thought I fixed that like 2 months ago, and then it just creeps back up. So wanted to talk to you a little bit about sustainment, because as you implement the things in patient experience, you have a lot of variables that change, right? New doctors, new nurses, new case managers. And so every time it's a new opportunity for something to fall through the cracks. And so I just share this as another little thing, but in theory, so sometimes I'll get asked to come help with bedside shift reports, say, or multidisciplinary rounds. And I'll say, tell me about your bedside shift report. And then they'll talk to me about it, and I'll say, well, let's go and see. And so what they told me happens is a great process, but what we actually see is this, right? Is that it's kind of fallen apart over time, and it's about process. It's not about people, it's all about process. So the important point here is that as leaders, you have to have a method to check back on some of these things and validate that what you think's happening is actually happening. And so we like to use a team to create new things, and so this is just my plug for team-based improvement of bringing key stakeholders together. This is actually 2 different teams, but the one on your right is a team working on developing their discharge process. And so we have EVS and our regional medical director there and several nurses framing out so that they become the champions of the work and it doesn't all fall on leaders' shoulders. And what we encourage them to do through that is build in things like AIDIT and timelines so that everybody knew how long it should take, and the leaders can see normal from abnormal and know if the process is working every day. 5 feet, 5 seconds. Bedside shift report is one that I think kicks off every day in a positive way if you can do it right. And, you know, it's important to include the patient, so, you know, it isn't standing at the door, and so it's sort of at the bedside, but it's more like halfway to the bedside report. And that was another one of those jokes, guys. And then, you know, having a schedule for it and then validating it regular. So I want to just show you if this video will work, a quick video, and as you, the leaders of the units are looking at this, kind of ask yourself if this is in line with what you're thinking and expect from your team. So let's cross our fingers. Here we go. Okay, hang on, Lily. I'll try once now. I'm not sure how to get the sound on the screen, so sorry about that. But I can let you all have the video if you need it. Okay, so interdisciplinary rounds, I had a chance to watch your rounds today. There's a missing component to them that's important. Does anybody know what it is? The physician, right? So consider that how you bring the physician into your rounds. It can be, you know, physician nurse rounding in the morning together and then an afternoon huddle away from the patient. Lots of different ways to do the rounds, but really to sync up and have that collaborative communication and letting the patients know that it's occurring. The communication whiteboards, so you have them think about what information is important to the patient. So what's the most important thing to the patient most of the time?
Who's caring for them?
Who's caring for them?
What the plan is for the day.
What the plan is, who's my doctor and what time are they coming, what time are rounds, but when am I going home? When's my discharge day? So having the anticipated discharge day up there is really important and another delighter. And then keep it concise, use layman's terms. Patients don't know what a PT is or NPO, anything like that. Did you guys want to?
Just the anticipated discharge date is something we don't hardly ever use in the hospital or that I've ever observed. I think that the feedback I've heard about it is that it becomes more of a dissatisfier for when we don't meet it, as opposed to maybe when we do meet it. The risk doesn't outweigh the reward with it.
I was just commenting, that's a good example of, there was an intention to do that, and on my particular inpatient unit, we had initiated that. I was very fortunate to have med education residents, so that was starting and went off pretty well, but it fell by the wayside, so it's a good opportunity to resume it.
We implement that at almost every one of our sites, and it seems, I mean, the feedback we get is it's great. We work it though, right? That it's anticipated, and we use it every day in rounds to validate. Yep, January 18th is the day we're thanking. And, you know, we might change it the day before. We don't put 1 or 2 days. We're pretty precise about it. And it just syncs everybody up and drives questions. So it's got to be iterative and changed every day and used every day as a communication. So,
You know, if I can just comment also,
Yes,
because what happens on some units, and I can speak to my unit again, is it's helpful, obviously, because a patient wants to know when they're going to be discharged, and it can be adjusted, and I think you've made that point fairly clearly. What happens sometimes, and it happens on my unit, is that patients don't want to go home, and they're very comfortable where they are because of other challenges that a particular patient may or may not have. So again, to be able to redirect them, because at the time of discharge, when discharge instructions are being given, and I've discussed this with my nursing staff, sometimes the patients are disgruntled that they don't feel like they're ready to go, as if they have not heard this. And in fact, if it's not documented on that board, and we have a variety of nurses and physicians that may be circling through, it's hard to speak to the fact that, well, I know it was discussed with you, and, you know, most importantly, you're ready for discharge. This is not the place you need to be. So it kind of works both ways, I think.
yeah, it's a great point of discussion to come up for sure. I mean, yeah. So I talked about sustainment earlier. So this is one tip that, you know, this is a board I used to use that I track processes so the staff knew every day what, and this is just one example, but the cards flip red or green so they know how we're doing. It's a visual again. And so our leadership team framed out our month of what processes we were going to observe and validate. So if we had something new we were rolling out, it might be every day for 2 or 3 weeks till it was hardwired, and then it might go to every 2 weeks and so on. This was right out on our unit. Some people prefer to have it in their office, but it's sort of calendaring your sustainment. So you really know what's going on in the unit, because there's so many things that, you know, impact and affect the standards that we put in place. So it's a great kind of a visual, gives you at a glance, anybody can come to your unit and learn, and red isn't bad, it's just an opportunity to improve. Just a little bit on patient complaints. I like to call them gifts or treasures, and you might have big ones or little ones. You get to choose which ones you open up, but make sure that your team is engaged with you, because it can be discouraging, and balance it with compliments versus complaints. So we used to do sort of an observe versus expected and have it posted on the unit, so that the team was trying to get more, you know, build their compliments, build their thank yous, and then the complaints don't seem as bad, and we want to open some more of those gifts up. This is just another plug for sustainment, but you know, if the team doesn't know, if you don't have a checklist or standard work, for that your coworkers, your team members know what good looks like, so you can't have one without the other if you don't have standards, flow. So anytime that you have things fall off, additional waiting, defects where you have to track back, rework, you aren't going to get the patient experience, because they know what's happening. And then keep everything transparent, and again, tight connections so that everybody's on the same page, and that can be in writing, that can be verbally, it can be through the medical record. And then, let's see, so we're almost done. So homework. So really, I encourage you whenever, you know, rarely is education education, more education, the root cause to not succeeding, it's a piece of it. So hopefully you found a pearl or two you can take back and share with your team, implement yourself, and give it a test. And then once you've hardwired that, pick a couple of more things, whether they're things I said or things you read about. You know, there's volumes of books we can read on patient experience now. So there's tons of pearls and subject matter experts. So, and then just pick 3 more things. You know, the other thing when I say practice, 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 sometimes we have to simulate with our team to get them to feel more comfortable. So think about how you do some of that role playing and simulation. Use a phone and just, you know, a cell phone and say, let's tape some of these and let people see what they're doing. You'll erase it right after, right? But any method you can get to get people to feel more comfortable and confident, lower patients' anxiety, and get them to engage in their plan is going to be a success. So thanks a bunch for listening.